Welcome, students, to Part 1 of the 150-part IPDRG Masterclass on Decode Healthcare with Harshal. I'm literally so thrilled you're here. In this explainer, we're going to map out the exact roadmap to take you from absolute zero to an expert inpatient coder. We're embarking on a massive 150-step quest together. And hey, don't worry if it sounds super complex right now. As your lead instructor, I promise we're going to decode everything, from clinical documentation and CDI queries all the way down to billing audits, step by step. By the time we finish, you'll have a rock-solid grasp on hospital coding.
But real quick, before we dive into the clinical details, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal.
Okay, let's look at the foundational pillars we'll be conquering today. We'll do a quick welcome to the masterclass, cover inpatient versus outpatient basics, look at core DRG data inputs, break down the reimbursement formula, map out the inpatient revenue cycle workflow, and finally, do a summary and next steps. All right, Section 1, welcome to the masterclass. Moving right along to Section 2, inpatient versus outpatient basics.
Let's lay down our first foundational pillar. We need to clearly delineate the differences between hospital settings, because honestly, how you code depends entirely on where the patient is actually sitting. It's absolutely crucial to understand that outpatient coding runs on a fee-for-service model. That means individual services get CPT or HCPS codes. But inpatient coding, that relies on a prospective flat rate for the entire episode of care. So if a patient is admitted overnight, the hospital gets a single lump sum based on their diagnosis. It literally doesn't matter if they stay for 3 days or 10 days, or if they had 2 x-rays or a dozen.
This flat rate methodology is governed by the Inpatient Prospective Payment System, or IPPS. Under IPPS, hospital cases are sorted into what we call diagnosis-related groups, or DRGs. The whole idea here is that patients who group into the same DRG are expected to consume a similar amount of hospital resources and have similar clinical characteristics. It's kind of like a giant bucket for similar cases.
Now, what's really interesting is the core difference between the two main types of DRG systems you're going to encounter. First, there's Medicare's MS-DRG system. This one adjusts for severity using comorbidities and complications, what we call CCs and MCCs. Then, on the flip side, you have the IPDRG system, which is often used by Medicaid. It takes a totally different approach by using a 4-level scale to measure the patient's overall severity of illness and risk of mortality.
Okay, Section 3, core DRG data inputs. To group a patient into one of these specific payment DRGs, medical coders have to act like detectives. We extract very specific data directly from the medical record. Your DRG grouper software absolutely requires a few key things to function. You need your principal diagnosis, secondary diagnoses, any major procedure codes using ICD-10 PCS, patient demographics like age, gender, and discharge status, and of course, those highly critical present on admission, or POA indicators. If even one of these is off, your entire DRG output changes. Let's zero in on the single most important input, the principal diagnosis. Now remember, the principal diagnosis isn't necessarily the primary reason the patient walked in the door. It's not just severe chest pain. Rather, it's the clinical condition established after study to be chiefly responsible for the admission, like an acute myocardial infarction. This diagnosis determines the base DRG category, so getting this right, totally non-negotiable. Another massive factor is the POA indicator, which can be Y, N, U, W, or 1. POA indicators are so vital because, let's say a secondary diagnosis like a deep vein thrombosis develops after admission. That gets flagged with an N for not present on admission. It becomes what's known as a hospital-acquired condition, or HAC. When that happens, CMS won't use it to increase the DRG payment tier, meaning the hospital basically has to absorb that extra cost. Moving to Section 4, the reimbursement formula. All right. This is the show me the money moment. This is where we look at the high stakes of getting your inputs right or wrong. Because in inpatient coding, your accuracy directly impacts the hospital's financial survival. The crucial point here is a seemingly simple formula. Hospital payment equals the facility's base rate multiplied by the DRG relative weight. CMS fixes the base rate based on the hospital's region. But that relative weight, that is entirely dependent on the DRG that you, the coder, assign based on the clinical documentation. Let's put this into perspective with a real-world scenario.
Say a patient is admitted with pneumonia. If a coder accurately captures a secondary diagnosis of COPD from the physician's notes, that acts as a complication or comorbidity, a CC. The hospital gets reimbursed $8,500. But what if that COPD code is missed? It triggers a DRG downgrade that literally costs the hospital $2,300 in lost revenue for that one single stay. That is the true financial power of accurate coding.
Okay, Section 5, Inpatient Revenue Cycle Workflow.
Because the financial impact is so massive, accurate IPDRG assignment isn't just a coder sitting at a desk in isolation. It takes a highly collaborative, well-oiled effort across multiple departments, from patient access all the way to denial management. Our coding and grouping phase sits right smack in the middle of the hospital's revenue cycle. We are the critical bridge between the clinical care being provided and the financial reimbursement the hospital actually receives. The linear flow of this team effort starts with the clinical teams, doctors and nurses providing the source documentation. Next up, the clinical documentation integrity, or CDI specialists, review the chart and raise non-leading queries to clarify any vague gaps. Then, medical coders assign the final ICD-10 codes and run the grouper software. Finally, the billing and revenue cycle management team steps in to submit the UB04 or 837I claims to the payers. Like I said, it is the ultimate team sport.
And finally, Section 6, Summary and Next Steps.
We've covered a ton of ground today, establishing our foundational pillars, and you should be really proud of what you've just mastered. Let's quickly review our main takeaways to ensure you firmly grasp this high-stakes reality. Remember, inpatient coding relies on prospective IPDRG flat rates, not fee-for-service. DRGs are driven by your PDX, secondary diagnoses like CCs and MCCs, procedures, and demographics. Reimbursement equals your base rate times the DRG relative weight. Missing a valid secondary diagnosis causes severe hospital revenue loss. And of course, the revenue cycle is a massive team effort from clinicians to billers. So, are you ready to dive into the medical record? Think about how these rules apply to real-world documents, because this is just the beginning. In Part 2, we are going to start actively navigating the patient chart. We'll break down the face sheet, discharge summary, history and physical, and progress notes so you know exactly where to hunt for these crucial data elements. Before we go, ask yourself, what hidden, undocumented details in your patient's charts are quietly costing your hospital thousands of dollars right now? Think about it. And hey, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Until next time, keep decoding.